Hi, this is Dr. Ed Kim from the Department of Surgery at UCSF and VA San Francisco. Welcome to the Guide to Classroom session for Part 2 of our Acute Abdomen module. The learner should come prepared by having reviewed the YouTube podcast on the Acute Abdomen Part 2, and this is on our YouTube channel of the UCSF Skills Lab. And this guide can be used as a standalone with the single module itself, or it can be combined with additional modules. There are 5 in total. The learning goals for this session will be to help our learners develop a rudimentary understanding of how to interpret CT scans to make it a more accessible tool in our clinical practice. And it's to help them understand specifically or help them identify early signs in acute abdominal processes, namely inflammation, and also to identify some late signs such as necrosis and perforation. And we will use the small bowel obstruction, the process of small bowel obstruction, and discuss its pathophysiology to help us achieve this task. And we'll discuss the differences in early and late radiographic presentations. As always, we should start by reviewing what was on the preparatory podcast, which is that the cardinal sign of inflammation that is detectable on scans is edema, which is related to swelling when inflammation occurs. Hyperemia can also be seen, which would correspond to the heat on physical exam, but not as reliable. And edema in the abdomen presents itself in 3 main ways: bowel wall thickening, free fluid, and fat stranding. So let's start talking about small bowel obstruction and discuss what's most important. What are the most common causes of small bowel obstruction? How do people die from an obstruction? This will help them understand what we need to look for. That historically it was probably due to dehydration, but now with modern medicine it's really because of perforation. So the main distinction that has to be made with people with obstruction is who is likely to perforate, what cases require urgent surgery to avoid or treat perforation, and which cases can be managed conservatively. There are 2 main types of small bowel obstruction. One is on the left is a closed loop, which is relatively easy and intuitive to understand. The fact that a piece of bowel volvulizes on itself and causes vascular congestion, obstruction of both inflow and outflow, and resulting in perforation and death. On the right is the single band type of bowel obstruction, which occurs much more commonly, and that pathophysiology and mechanism is a little bit harder to understand, partly because you'd expect somebody with an obstruction and dilated loop of bowel to vomit and decompress themselves before getting into trouble. Well, this is part where we can we can go back to our prior understanding and what we learned previously in Module 1 regarding the pathophysiology and mechanism. It's important, vitally important for retention and for overall understanding that our learners have a physical mechanistic way to understand a adhesive bowel obstruction. So going back, you have the obstruction, distension, obstruction, and which causes distension, which causes visceral pain. It's often crampy. It's mildly diffuse in terms of tenderness, not true tenderness. And in addition to distension causing ischemia at the level of the capillary abdominal wall, which our learners should be familiar with, we need to bring in and emphasize a second mechanism, which is the direct pressure of the adhesive band on the bowel, resulting in additional compromise of vasculature in that area. This all results in inflammation with bacterial translocation, which can result in perforation, eventually leading to diffuse tenderness and parietal pain. Or before that actually happens, there would be focal tenderness, there would be focal inflammation around the band and just proximal to it, which is where we often see perforation occur, if it occurs. So for our first exercise, we should encourage a discussion on what is the mechanism that leads to one type of small bowel obstruction to perforate and one not to perforate. This is where I think we need to supplement our learners' knowledge with this idea of partial versus complete. That in general, we usually think of small bowel obstruction in two different type of categories, and we want them to come up with a physical reasoning for this, and hopefully they can use what they have learned from Module 1 and come up with the idea as they go down the mechanism, how it actually occurs, the obstruction, the distension, and the vital step being this compromise of our mucosal integrity, the barrier mechanism because of ischemia, and that they'll be able to articulate that it is the degree of pressure, a physical phenomenon that distinguishes a dangerous small bowel obstruction from not a dangerous small bowel obstruction. What would be the difference between a high pressure and a low pressure obstruction, given that it is due to the band? And again, it's the idea that distension and tightness. And this is where we can start thinking in real life terms, or in real physical concrete terms, the idea of partial or partial or complete bowel obstruction, and also the term high grade versus low grade obstruction can be used, as the partial versus complete can also cause some confusion. And continuing on to exercise 2, we should ask the learners to describe how somebody with a dangerous, presenting with a dangerous obstruction would present or would look like, what their history would be, what their exam would be. And one of the key parts of the history we always focus on is this idea of obstipation and constipation. And it's an important part of the history, but we also need to help them recognize that there's limited reliability of this information, and encourage them to picture what is physically happening in the body, particularly with this with the entire process, but also to help them talk about this obstipation constipation. And this is where I think this video of a CT scan of an obstruction can help, because what I would point out in this CT scan, which we'll reviewed again, that it is a bowel obstruction, and at the end part right here is where I would focus on to help them to show them concretely in real life what actually is possible. In this patient with the high-grade bowel obstruction, they have stool and gas in the colon. So by showing them this, I think it makes it very clear to them that even if you have an obstruction, you could still have a bowel movement or gas, even if it's a high-grade obstruction. And that the key element that makes this part of the history more reliable is the time, the duration of obstipation and constipation. So if somebody comes in without having had a bowel movement for 1 day, that is not nearly as reliable as somebody who hasn't had a bowel movement or passed gas for 3 days. So having discussed the differences between the high grade or the dangerous and the not so dangerous obstruction, again, the not so dangerous obstruction and the differences should be discussed in terms of the tightness of the band and the degree of distension and the pressure. A partial bowel obstruction is not so tight, it allows the gas to pass through. Having discussed all that, now it's time to discuss, to introduce the idea of clinical acumen, that we're looking for early diagnosis, and that the video podcast and talking about inflammation and bowel obstruction didn't focus on free air like on the x-ray shown on the left. And this type of material and the information is has been introduced to the students usually at an earlier level, because it is very dramatic. The idea of pneumatosis, as shown on the CT scan on the right, the top right, and also a more dramatic scan of free air on the bottom right. So these are late signs, and what we want to impress on the students here is that a good clinician is one that doesn't necessarily that doesn't detect or that doesn't see a patient in their late stages of the disease. It's important to emphasize that anybody can diagnose somebody with an acute perforation, because they will look very sick and they will have these very obvious signs. And the key to being a good clinician is being able to see people or to detect problems or suspect problems early in the process. And the early in this difference between early versus late as determining a good clinician from a mediocre one is an important one. I think that applies throughout all of medicine. So for bowel obstruction, the idea is that we catch people in this cascade of events, not at the level of perforation. And somebody might present obviously in perforation, and that's not within our ability to control. But when somebody presents earlier in the process, we want to catch them when they are starting to have inflammation or showing signs of bowel that is under threat. And this is when the inflammation occurs, that the bowel is not happy because there's some vascular compromise occurring, and it is on the verge of potentially going into infection and necrosis and perforation. And we want to catch them before that. So in exercise 3, we again have patients present contrasting patients, partial without evidence of bowel compromise. So they can do a short one-liner or a few lines of a history summarizing what the important points are. And then present somebody with partial without evidence of bowel compromise, present somebody with complete with early evidence of early bowel compromise, and complete with evidence of perforation. And then have them practice in this specific exercise to organize the clinical information into the 4 categories of history, exam, laboratories, and studies. We want them to be organized, especially for the students, in the information and categorizing them so that they have a way in which they don't jump around between the categories of information. For exercise 4, I would review the CT scan, which was shown previously as a proof to the students that you can still have why people can still have constipation or bowel movements after during the course of a small bowel obstruction. So it's the same CT scan. And have them look at it and review it. And this is, and one of the things that we should discuss is to discuss how to determine the difference between small bowel obstruction and Ilyas. And if you have a good scan of somebody with an Ilyas, this would be also a good time to present it as a contrasting view. Remember, the seeing these things will mean so much more to our learners than just talking about it. And that's why it's important, like I said previously, to show the stool in the rectal vault, in the colon, and the gas in somebody with a high-grade obstruction, because that's something that our learners will be able to wrap their head around and accept as a reality. So in discussion of diagnosis of small bowel obstruction, I think everybody or a lot of people are familiar with the idea of transition point, that, we have to find where this band is. But in reality, if we're trying to teach early novice clinicians, finding the transition point can be even difficult for an experienced radiologist. The easier way to go about it is to look for decompressed bowel, and I think this is an important point and skill to provide to our learners, that if you're looking for the difference between Ilyas and small bowel obstruction, if you look for decompressed small bowel, then even if you don't know where the transition point is, at least you've made a fairly reliable distinction between a bowel obstruction versus an Ilyas. Obviously, air fluid levels can be present in both. And again, that's one of those classic findings that everybody seems to know about and get excited about, but unfortunately doesn't have that much clinical significance in terms of our management. And also to go over, obviously, the 3 early signs of inflammation, and to also discuss the idea of IV contrast becoming more and more accurate or sensitive for assessing perfusion in loops of bowel. So this would be the scan to show, which shows there's small bits of free air under the right diaphragm. And this is a high-grade perforated small bowel, but it contains hyperemia. You can see the fat stranding, and you can even see the small area of perforation right there. So this is an excellent scan to illustrate all the different elements that we discussed. And so finally, depending on how much time you have and how many other modules you're covering on the same in the same session, it would be good to review films of other acute abdominal pathologies. And this doesn't obviously have. This can also be done during the course of cases that occur throughout either the rotation or once a year. So pathologies such as appendicitis, diverticulitis, large bowel obstruction, and have them correlate narratives with clinical findings. What symptoms would you expect for somebody with these findings? What vital signs would you expect based on seeing a CT scan? What physical exam findings would somebody like this exhibit? And what laboratory values would be also associated or likely? So in this, this is a patient with a perforated diverticulitis, but it's a limited perforation. And as you scroll down to see scan, you can start to see the area of interest with the increased, and it's a little bit more subtle, fat stranding right there with a little fluid level indicating perforation. And it will be important, and we will also try to provide additional cases with interesting and instructive scans that you can also use during this session as well. They'll be posted separately. Thank you for listening.